All right, this is the third video and the last video for the ankle foot. What we're going to talk about now is some specific rehabilitation applications. So I thought you would like starting with this really exciting slide here. Here you are. I hope it isn't too overwhelming. Ankle rehab. All right, moving on. So the first thing we'll talk about ankle sprains because they are very common. Most often it's the anterior talofibular ligament. Sprains of the anterior tibiofibular. So if we look on our little picture up here, it's the anterior angle. So the anterior tibiofibular ligament are a little bit different. This requires, tears of this ligament will require extra care since the ligament stabilizes the distal tibiofibular joint. And every time you step down, that joint is stressed, and so the tib and fib kind of spread apart, again, making it difficult for this ligament to approximate and heal. So don't be surprised if somebody has what we call high ankle sprain, so an injury of the anterior tibiofibular ligament, and they have to be on crutches for a while. But right now, let's address anterior talofib ligaments. Those are the most common. So the first step is to control the pain and edema. We've got different ways that we can do that with its modalities or elevation and compression. So that's our first rehab goal. The next thing we want to do is initiate some range of motion activity, and we want to try to start that fairly early. If we have a grade 1 sprain, we'll typically start active range of motion in 1 to 3 days. That's, I believe, what is open on your outline. So 1 to 3 days with a grade 1. If it's a grade 2, we'll start active range of motion closer to 4 or 5 days, and a grade 3 will be more somewhere in between 5 and 9 days. We start some active range of motion. The exercises that you absolutely have to include at some point. These are the most important exercises for ankles that have torn or partially torn their ATF. Is to improve ankle eversion, because we have to strengthen the muscles around the ligament that was torn, and typically those are the everters. So we need to work on strength of that, as well as proprioception, and also being a key to ankle stability. So oftentimes the peroneals will get strained along with the ATF sprain, so don't be surprised if pain goes up the lateral side of the leg. That should resolve in time, and especially when you're doing ankle strengthening, that should help with recovery of that. In general, it's said that for 6 months following an injury, bracing or taping for activity is probably a good idea. Of course, it will depend on the severity. More and more studies are coming out, though, that say that bracing might be the way to go, especially when we're looking at cost effectiveness. So you can keep that in mind too. What I have in this slide is when we're in the phase 1 of healing, just a reminder to control pain, limit edema, and then work on regaining range of motion. As we move into the second phase of healing, we have should show increases in range of motion, that's active range of motion, strength, and then working on proprioception. And then in phase 3 of healing, there should be full range of motion, strength, proprioception, and moving into functional activities. With chronic ankle sprains, it's a little bit different. There's usually scar tissue from previous strains that may have created additional adhesions and limited the joint and soft tissue mobility. So we might actually have to get in and do joint MOBs if it's indicated. And why would it be indicated? We have a loss in range of motion that's in a capsular pattern. Chronic muscle weakness may have resulted from a lack of proper rehabilitation. So it's not unusual for somebody to sprain their ankle and not really do anything about it as far as strengthening. So that ligament does not return to shape, and now they've just got this slack ligament at that joint that could easily be re-injured because it doesn't provide any stability. It's no longer nice and tight, and so we get resultant weakness because we've never really trained it. There's reduced kinesthetic awareness from previous sprains that makes the ankle or the area susceptible to more sprains. And sometimes compensatory gait will show up, and that can increase further injury risk. And then additional time may be required to fully rehabilitate a chronically injured ankle. So if you have an athlete or a client that continues to have ankle injuries, just know that it's going to be a little more time than our typical ankle rehab. If the injury was so severe or chronic, here's some exercises or just common ankle rehab things that we'll do. Here on the right is some eversion with the blue TheraBand, which is the higher level. On the bottom here, these are called ankle tough bands. They come in different colors. They come in a nice little kit with instructions, and you can hand them to the patient and tell them to start with white and move up to yellow when they're able to do the recommended number of repetitions. And again, we got to make sure that they're doing eversion, so those are really some of the more important ones. And then proprioception, which on the left side, there's a couple ideas for proprioceptive exercises. You can get really creative on these. So a couple surgeries that are listed in your notes. One is the Brostrom procedure. And with the Brostrom ankle reconstruction, it reconstructs the ATF with the retinaculum of the ankle. So we can see in our picture here, we've got this ATF that is really slack, and it's not providing much stability, and probably the CF down the middle here as well. And so they'll take the retinaculum that comes over the dorsum of the foot, and they'll restructure that so that becomes a new retinaculum. Or they may suture that ATF and the CF back together to make them tighter. And this would be somebody that has chronic ankle sprains, and because of this they had chronic ankle inflammation that could lead to early arthritis. So somebody would have to be in pretty bad shape, and that it's affecting their functional ADLs, their activities of daily living. Typically with this surgery, a patient will have to avoid inversion and adduction of the forefoot for 6 weeks post-op, and you can imagine why, because this could easily rip the sutures, so it has to give it time for the ligament to heal, or at least get an approximation of tissue there. That's not going to be ligamentous tissue, it'll probably be scar tissue in there. And early rehab, if we're able to do it, we'll probably start in the pool. So a good time to do the aquatic therapy. A modified Brostrom is in this picture, and they take the inferior extensor retinaculum here, and they pull it up onto the fibula, and they suture that in to make this whole area even more snug to help reinforce the repair. Here's a couple other different surgery techniques. The Watson-Jones procedure in A here is one where they take the peroneals and they reroute them around here, and they make a new anterior talofibular ligament out of that. So that's one procedure that's done. Sometimes they'll do the Evans procedure, which is B, and they'll take that peroneus brevis and they come again rerouting it, going through the fibula on the outside but across the same area that the ATF would be. And then there's the Christman-Snook procedure, where they take the peroneals and they do a fairly lengthy procedure to come through the fibula and wrap around into the calcaneus and then come up again and bind that off. This would be one that's done on somebody that's fairly unstable. And then there's modified versions of the Christman-Snook procedure. The, C is the one that I had done. So I'm fairly sure this is not exactly what they did. They didn't come through the calcaneus, so they did a modification through here, through the fibula, and then tied it off and through there and kind of reconstructed a new ATF for me. When somebody has a surgery like this, they usually come from the physician with some pretty specific instructions on how long they have to wait before they go into eversion exercises, how many weeks, and how many weeks before they can do some stretching for inversion. Don't want to get into this quite yet, so I'm going to go back a slide. For this, your notes, I have preventative measures down there under training techniques, good peroneal muscle conditioning. So if somebody has chronic ankle sprains, make sure that they're strengthening their peroneals. Watch them when they land, that they land with a wide base of support. The more narrow they are, the more likely they are to roll roll into an inversion sprain. Ankle taping and bracing can be helpful. Some of the research will show that bracing is associated with a lower incidence of ankle injury than taping, although that is debatable. Of course, there's semi-rigid plastic stirrups, there's air casts, there's all sorts of things that we can use post-injury. I tend to not use a lot of these. We'll get ice and an ACE wrap on, get them non-weight bearing till the inflammation is under control, the pain is under control, and then start them on eversion strengthening, and then working on whatever range of motion that we have a loss of. So the next one is B that we're going to talk about. And some of you will recognize this athlete is Kurt Schilling. I'm going to talk about peroneal tendon subluxations and dislocations. These dislocations are often overlooked because they frequently occur with other injuries. So somebody has an inversion ankle sprain and the peroneals pop over the lateral fibula. Let's see if we can get a picture. Here's a decent picture of it here. So here's our peroneals, and they're catching on the posterior fibula, and if this retinaculum, which we don't have a picture of here, tears, then these peroneals will start to snap over the fibula when you go into plantar flexion and dorsiflexion between those motions. So two mechanisms that cause this is ankle dorsiflexion with an active peroneal contraction or an inversion sprain. In an inversion sprain, they're most susceptible to an ankle dislocation if they're in 15 to 25 degrees of plantar flexion, because the more dorsiflexed your ankle is, the more close-packed that ankle is, and the further you go into plantar flexion, it's more loose-packed, and so we don't have the bony congruency or integrity at that position, so we tend to see more dislocations of the peroneals taking place at that angle. Usually they'll self-reduce, so if this pops in front of here, when they move their ankle around into plantar dorsiflexion, just kind of waving it back and forth, it'll pop back behind there. Sometimes we'll use a felt pad to try to push that peroneal, so we push a felt pad, a J pad, right up in here, made out of really thick, dense foam, and tape it on. That's usually not really very effective. People who dislocate often end up having to go in for surgery. So I'm going to go back and just tell a brief story about what happened with Kurt Schilling. And Kurt Schilling had chronic peroneal subluxations, and so in the World Series, he's pitching and hadn't completely rehabbed. They hadn't controlled this, and so he's pitching, and he starts to have a lot of lateral ankle pain, and they take him off of the mound and bring him back into the training room, and his peroneals, which run right posterior here, are flopping forward or folding forward because he doesn't have a retinaculum here to hold them back. So they actually put an anesthetic in, and they put sutures in the leg right through the skin into the periosteum of the bone, and they try to build a wall here so that the peroneals won't shred across the lateral Malleolus, and sent him back out on the mound. So he continues to pitch. Well, the sutures start to separate, and he starts to bleed through this, and he becomes this famous, well, he was already famous, but this hero now because he continues to pitch with the bloody sock that ends up in the college, or not the college, but the Major League Baseball Hall of Fame. And I think years later sells for over like $92,000 or something at a private auction. But it just demonstrates that these are difficult injuries to control and work with, and so they often will end up going for surgery. Post-op, they're non-weight bearing for about 4 weeks, and then when they come out, they just have to slowly work on perineal strength recovery, and so it's a lot of eversion on these. Here's a little picture of the retinaculum that rips off or can rip off, and if there's enough to save, they may go back in there and suture that back together. Oftentimes, though, it'll be split in a way that you can't pull it back that tight, or it's shredded to pieces. All right, just talk briefly about Achilles tendinopathy. It's kind of this big category now that the word that we use because we don't necessarily know if it's a tendinitis or a tenosynovitis, so we call it a tendinopathy. We got inflammation of the Achilles tendon. Could be chronic, could be acute. Usually it's about 2 to 6 centimeters proximal to the tendon insertion at the calcaneus, so here on this X is a common place for it to occur. We need to try to correct the cause, so we'll look at subtalar neutral, see where they're at, see if we need orthotics, see where there's weakness around the foot and the ankle, see if we've got decreased flexibility in the gastroaxilleus complex. The onset is typically gradual and is associated with overuse. Possible causes could be prolonged pronation, inadequate or improper footwear, and again, weakness. Pain progression follows typically a tendinitis pain or a tendinopathy pain. And a tendinopathy pain has oftentimes 3 progressions. So the first sign that you see is they'll have pain in this area after activity. And that'd be like we'll sometimes call that a phase 1 tendinitis. And then a phase 2 tendinitis, they have pain during their activity and also for a few hours after the activity. And then a phase 3 is they have pain in the Achilles even before activity. So just doing their activities of daily living, they have pain there. And that's really where it becomes a fairly significant problem because it's affecting your ADLs. You can't even walk without pain. So that's what I mean by a pain progression follows a tendinitis. When you do your examination, sometimes you'll feel a scar tissue kind of in this area, that 2 to 5 centimeters proximal to the insertion. And oftentimes it's more medial on the medial half than on the lateral half. Be careful, though, that you're not mistaking this for retrocalcaneal bursitis. So if you rub or pinch, palpate on the top of the tendon and that's painful, then you're looking at Achilles tendinopathy. If you come behind the Achilles and you actually grab maybe a little closer to the calcaneus and you grab it behind there and you kind of squeeze your thumb and your forefinger together, so your thumb on one side, your forefinger on the other, and you squeeze and they have more pain with that, it actually might be a retrocalcaneal bursitis, which is very different. We would potentially do friction massage to a tendinitis. We wouldn't do that if they had a bursitis. It would make them worse. We'll use ice to relieve pain with a tendinitis. For a bursitis, that ice typically is not very effective. So know what you're dealing with, whether it's a tendinitis of the Achilles tendon or if it's the burst of the sac that sits right underneath the Achilles tendon. On your notes it says Jan's POIs, that means Jan's points of interest. So if you look in the book, there's a lot of information about this, so I pulled out what I thought was most important and I'm going to share that with you here. Achilles tendinopathy can be slow to heal due to a hypovascularity. So just remember that. They're a fairly long rehab process. You need to reduce the offending activity. So if running hurts, they can't run. If walking hurts, you got to get them off it. You got to put them on crutches. Sometimes we'll use heel lifts to elevate the heel so we don't have tension across there. We tell them to be in shoes. They shouldn't be walking around in barefoot until the symptoms decrease. Quit running hills, especially uphill, because that has to lengthen the Achilles. So those are some ideas that you might want to review with your patient in your history of what's really going on or what's causing the pain. We'll use modalities and cross-friction massage sometimes to decrease the pain. We'll strengthen the gastroc with pain-free activities. Pool rehab is great because we can decrease the amount of weight bearing. You must progress these people into some sort of eccentric strengthening when they're able to do that without pain. So in your notes below, I have a heel raise eccentric program for someone with Achilles tendonitis or tendinopathy. So what they're doing is going up with both legs and down with just the involved leg, and they're on an incline board. So phase 1 would be 3 sets of 10 reps, and they do this activity slow with just their body weight twice a day. And functionally, they should be able to just go around and do their activities of daily living symptom-free. And if that's achieved, then they can go on to the next phase and continue on through the phases. But it's a nice progression. It works them into eccentrics. Eccentrics is going to develop our force faster. So it's important that we do the eccentric program for these people, or at least teach them that. Just a real quick note on Achilles ruptures. We don't see those very often, and there we got our picture of it. So this guy or gal, I think it might be a guy. So we got a ruptured tendon, and obviously we have the rupture clear up here, and it looks just shredded down here. I'm not sure what happened. I don't have a history on this. But the tendon can rupture, and I've heard of them actually rupturing and recoiling clear up the leg, and they have to go in and try to grab that tendon and bring it back down and suture it back together. It commonly will occur in people in their 40s and 50s. If it occurs in younger athletes, it's when the foot is anchored and they're pushed forward and puts a sudden stretch on the tendon when their foot was planted. There's nothing else except surgery for these people. There's no rehab when these rupture. They're going to have surgery. They're going to be immobilized for a significant period of time. And the rehab is long and slow because we have to really work on returning range of motion and strength in a way that doesn't aggravate them and cause a lot of tendinopathy-like symptoms. So hopefully you'll never have one of these that you have to rehab in the clinic. In 5 years, I think I only had one, which wasn't too bad, but they're really a long rehab process. All right, I'm going to touch on the next one, which is shin splints. And shin splints is really just an umbrella category. We could call it a medial tibial stress syndrome. We could call it posterior tendinopathy, anterior tibialis tendinopathy, stress fracture, and could be all of those. Oftentimes, if it is an area that is 2 or 3 inches long, we're talking about a tendinopathy. If it's pinpoint on the tibia, then we're more suspect of a stress fracture injury. So really, we don't do much to a stress fracture. So on the POIs, points of entrance, make sure that you've ruled out a stress fracture. If that's not ruled out, or if they do have a stress fracture, then we're just waiting for the bone to heal. So we're going to decrease activities and potentially weight bearing until that bone heals. And then we start working on some strengthening exercises. But if we've ruled out stress fracture and we have medial tibial pain, kind of in the distal third, it most often is an inflammation of the tibialis posterior. So first of all, they might have to be put on what we call active rest. So they aren't just sitting around doing nothing, but we're trying to find an activity that doesn't inflame or causes symptoms. So sometimes we'll use a stair climber. If that is not successful and they have pain with that, then we might move to water jogging or bike, whatever you have available. We want to keep their cardiovascular system going without causing symptoms. So that's kind of what we're after. We might want to correct poor gait mechanics. So we're going to be checking subtalar neutral, addressing shoe wear, maybe adding supports or cushions. A couple things you really want to make sure you address is the gastroaxilleus flexibility. How strong are the foot intrinsics? How strong is their posterior tib? Posterior tib strengthening exercises are very, very important. So you need to know a few of these. I think I have in your notes a URL for a YouTube that if you pull these notes up on Moodle, you can just click into that YouTube and watch that. But the point is in order to work the posterior tib, we need the ankle placed in plantar flexion and some inversion. So one exercise that I'll sometimes do is have somebody do heel raises with their with a tennis ball between their heels. So they're pushing together, kind of an inversion motion. The toes are touching, and then the heels are separated a little bit. So they're kind of in an inverted position and doing calf raises. So that's an idea. You can also put them on a step and have them work on just moving from pronation to supination, pronation to supination, and that can sometimes be effective for strengthening the posterior tib as well. The use of a air cast, a long leg air cast, has been shown to be effective in decreasing pain with stress fractures. We're not sure why that is, but the study was done that they put long leg air casts on a group that had medial tibial pain, and then the other half they did not use a long leg air cast, and the symptoms significantly decreased with the people with the long leg air casts in 21 days versus 77 days for the people that did not use the long leg air cast. So I've tried using this in the training room and have actually not been very successful with this, primarily because athletes don't want to wear a long leg air cast. So now I just present it. I am giving them the information as to what I would potentially do, what I'm recommending, and I let them choose. And just say that this could cut your rehab time in half. I don't know why it works. We checked the research, the literature last year to make sure that there's nothing new out about this, and that somebody hasn't said, no, this is a fluke, this isn't happening. But the research is still standing out there, and it was done in the 80s, and I haven't seen anything updated since that has refuted this. So. Just a note that if somebody has a severe stress fracture and they go in for a bone scan, and I don't know if no, we don't have a picture, but if on the anterior tibia up proximal, this is posterior, but if it's on the anterior tibial up proximal medial, they have what we call the dreaded black line on a scan. Know that those don't heal very well typically, and they have delayed union. And something like that is going to have surgery. And what they do for those is they put an intermedullary rod down the shaft of the tibia. We have had one athlete at Bethel that had that done. And then they had to do some bone grafting as well. So I just wanted to make mention of that. I don't have a lot of notes on this one, but just a reminder that there is something called Tarsal Tunnel syndrome, where somebody has compression of, remember Tom, Dick, and Harry? Here they are. So not so much the tendons, but we have a posterior tibial nerve and artery and vein that come through there, and that flexor retinaculum can be really tight, or you can have pressure in that area or inflammation that restricts the blood flow or presses on that tibial nerve, and you get tingly symptoms down into the foot, medial foot. So just be aware of that, that can happen, and then what we're working on is trying to decrease that tingly sensation with modalities or active rest. That's about all we can do. All right, plantar fasciitis. Plantar fasciitis will oftentimes be one that we use orthotic therapy for. Getting them to an orthotic. Here's the picture of the plantar fascia. This is where it's at. Oftentimes they have pain at the medial heel in this area, kind of where that green arrow starts, that stretches all the way up to their metatarsal heads. It's a connective tissue. There's not a contractile component to it. It hurts really bad in the mornings when they get up. So some things that we'll mention to them is to not walk around barefoot. That causes more of a stretch in the plantar fascia area. Use a heel cup because sometimes that heel area is really painful, and if they can get a cushion under there, that can decrease the symptoms quite a bit. Arch taping might be helpful so that that arch can't completely stretch out. That plantar fascia won't become more and more strained. Night splints is used sometimes to keep somebody in a dorsiflexed position. Is useful so that when they take that first step out of bed, it doesn't immediately re-stretch and strain that plantar fascia on the bottom of their foot. Lots and lots of heel cord stretching, so calf stretching, plantar fascia stretching with a great toe stretch. And a study came out last year that said that if you do this non-weight bearing, so if you're in the position on the left and you pull that great toe into extension back to you, so you're stretching the calf, you're stretching the plantar fascia and the first metatarsal phalangeal joint into extension, that you actually get better results, so better stretching than if you're weight bearing and trying to do that stretch. So you can think about that. Anti-inflammatories are often used because this is something that lasts for a long time. They say it's self-resolving, but that might take 2 years. I wouldn't want to wait 2 years for this to get better if I had it, so I'd probably work on all the rehab stuff we've mentioned so far. If this ruptures, we have an acute rupture of it, and actually this year was the first time I'd actually seen anybody with an acute rupture of the plantar fascia. It's non-operative. Long term, they may have a loss of medial arch and may have to get some custom fit orthotics. But you strengthen up the intrinsics of the foot, get them to a normal gait, and just see how they function. And then you can just go from there depending on their symptoms. Ankle fracture is the last one that I have on here. Usually they'll be, when they come to rehab, they're going to be partial weight bearing for a period of time during the immobilization. The common complications are their joint stiffness, especially of the talocrural joint, and just getting that motion back. Atrophy of the lower leg, abnormal gait patterns. It's especially easy to start to lose strength in the core, so you want to remember to work the proximal, especially glute max. Start at the hip and thigh early to prevent atrophy and gait abnormalities if you see those begin. And then you really kind of treat what you see wrong. So if we have a loss in range of motion, we treat that. Stretches and joint mobs. If we have a loss in strength, then we start bringing out some of those strengthening exercises that were on the previous PowerPoint and talking about how we can strengthen up where we see weaknesses. All right, so for the lab on Thursday, here's our case study as a 19-year-old female soccer player, and she's post-op Brostrom reconstruction on the right ankle on 2/14/14. When she walks, her pain is a 1 out of 10, so not very significant, and the doctor said no impact activities for the next 3 weeks. So that's your parameters. Objectively, she's ambulating with a slight limp. She doesn't have any crutches. She ambulates with a slight limp because she has difficulty with toe off. Her active range of motion is there. So dorsiflexion, she's got 7 degrees out of 20, which is what we measured on the opposite side. So on the right-hand side of the hash bar is her normal on the other side. For resisted range of motion, like dorsiflexion, she's a 4 out of 5, so her strength isn't bad, but that plus indicates that she's got some pain at the ankle with that. So both of those are, or all of those are there for you. And then her best test scores are also on the bottom of the page, so be sure to look at those. In lab, what could you be called upon to demonstrate for this rehab? It could be active range of motion exercises for any of the directions that we would work at the ankle. Passive range of motion might be joint mobs, so make sure you review your mobilizations that you could demonstrate those to each other. There might be some PNF stretching, so review, contract, relax, hold, relax. Might be some PNF strengthening, so review all the techniques in the D1 and D2 patterns. when we're doing PNF strengthening and we're working primarily at the ankle, make sure that your resistance will be primarily for ankle. So that hand that's distal or towards the foot really has to be providing a lot of resistance. Can you demonstrate how to teach them how to perform isometrics for those directions, isotonics for those directions? That can be with cuff weights, TheraBand, TheraTube, whatever you decide. And then some agility drills, proprioception drills, and then what kind of cardiovascular conditioning. And so I'm giving you a chance to think about these ahead of time. Hopefully come up with some answers. Each of you are gonna, you're just gonna pull out of a hat, and what you get is what you get. And that's what you'll demonstrate to the group. For those of you that are in the athletic training program, these are your checkoffs. So if you correctly demonstrate joint mobilization for dorsiflexion of the ankle, you receive a pass on joint mobilizations, and you would not have to repeat those unless you just happen to choose that at a later case study. So we want to try to get all of these checked off in our labs every Thursday as best we can. So have a great night, and we'll see you guys on Thursday in the athletic training room.